Hello everyone. So I think all of you know that we have started an interesting series on instrument suture material and tips and tricks, because sometimes we feel that explaining too much thought process and too much idea behind what we are doing in OT is not possible sometimes while you are already operating and your mind is focused for the patient. So we thought anyway these things we can discuss in a much better way in outside the OT in our comfort zone. So first session what we did, I hope you all have watched it. That was an interesting session on tension-free vaginal tape by obturator approach, which is also commonly known as transobturator tape. So today we are going to discuss a very common surgery. I'm sure that all of you would have done it. If not done, at least assisted or would have seen the surgery, because it is done everywhere in gynecology. It is called vaginal hysterectomy, and we are going to discuss about vaginal hysterectomy and repair. So I have another second year resident today to discuss the same with me. And before we begin the session, I want to ask her a question. Nipasa, what is the meaning of your name?
It means someone who's been loved by a
Okay, beautiful. So when I met you for the first time, that was the first time I heard this new name. So I really liked it. And the meaning is also beautiful, and we have a lovely girl today with us to discuss that. Let's see how much interesting and how much useful we can make this discussion for you. So can we start?
Yes.
Okay. So Nipasa, imagine that a patient will take it that this model is anesthetized and the position is lithotomy position in OT, and patient has been given, usually we do vaginal hysterectomy under spinal anesthesia. Patient is painted, draped and ready. We'll start from here.
So first thing we do is we catheterize the patient now. For that here.
Actually, before that I want to tell one thing. A very important thing in vaginal hysterectomy, which I feel, is that you would have, I'm sure that you would have seen in one year many vaginal hysterectomies. But the important question is, do you feel that two people do the same vaginal hysterectomy?
No. Every surgeon has
a different way of doing it. I feel for students, this is the biggest challenge, because no two people do in this exactly same way vaginal hysterectomies. More or less it is true for every surgery, but it becomes too complicated when it comes to vaginal hysterectomy. And as we grow in surgery, we pick up our own ways to do a particular step because of some particular mindset or reason. But more important reason is that no prolapse is the same, okay? Because there are so many variables. There are like prolapse, uterine prolapse can be associated with urethrocoele, cystocele, intracoele, rectocele. All those 5 components again can be on different degree, 1, 2, 3 degree, or if you do POPQ, many stages. And then all these things also, with or without stress urinary incontinence. So if you take all these variables together, it makes so many permutations and combinations that I read one very beautiful line somewhere that in one lifetime you cannot see 2 vaginal prolapse cases which are exactly same, because there can be so many permutations, combinations. So this increases our way of doing in complexity, and more so when a PG sees this. And one more thing, the anatomy becomes like when you are doing abdominal hysterectomy, you know this is the normal anatomy. When it comes down, the anatomy is totally distorted. So I think first few cases you don't even, when you see those cases, you don't even understand from where the bladder is coming, from where the rectum is coming. So I understand that it is a complex surgery, and there is no standardized way, and we cannot make everybody who is doing the correct way. So what we are going to do, we will tell why we do what we do in the OT. So first thing, Nipasa said that we put Foley's catheter. So many times you would have seen that people do not put catheter. Okay. So what they do, they put a metal catheter and then keep on draining it. Okay, before intermittently they keep on draining it. What I realized, I also started like that, but in due course of time, what I realized that anyway, empty bladder is always good, because at least if the bladder is empty, you have this thing in your mind that one place you don't have to put your mind. Okay, so post-operatively also patient wants. So even in laparoscopic surgeries, I have seen people intermittently catheterizing. So why do you want to put one extra thought in your head that you have to remember that you have to keep on catheterizing, and you might forget it at some time when you are in the very beginning of starting your surgical career. So what I suggest also, and I always do, I put Foley's catheter from the beginning only, and then just take away this thought that I have to think about bladder getting filled in between. When you have any confusion about the extent of cystocele, when you are not able to, in that case, metal catheter helps to delineate the lower border of cystocele. We have shown it sometimes in your videos. You can go back and see those. Okay. Suppose the patient is catheterized, it is connected to the urobladder. Then what else?
After that, we take the sim speculum and we retract the posterior vaginal wall with one hand. And then we try to see the prolapse. For that, we take the valsalum. And with that, we hold the cervix, and we bring up.
So you said that we will retract the posterior wall and will hold we can use one more speculum to see to lift the anterior wall up and then hold the cervix with the valsalum. Now there is a very important trick in holding the cervix, whatever, whether you are doing vaginal hysterectomy, you are doing laparoscopic hysterectomy, or you are doing a simple procedure like DNC or Mirena insertion or anything where you are using valsalum. So this is the vagina, model of vagina and uterus. Hold it like this. Okay. So here is the cervix inside the vagina. Now what I want all of you to understand that once you retract everything, you see the cervix like this. And when you are holding it with valsalum, always do one trick, that open the valsalum and put one claw of valsalum inside the cervical os. You should always hold it. Otherwise, some people, students, they are scared, they will just hold little tissue. That doesn't work. The only trick is that you have to put this valsalum inside when patient is under anesthesia and then hold it. Hold the full thickness. That makes the job much easier. So this is one more trick. Whatever procedure you are doing, it will help you to straighten the uterus in a proper way. Okay, so we can keep this also here. Then what do you do? After you have retracted, held the anterior wall, anterior lip of cervix with valsalum, then what is the next step?
So after that, the next step is hydrodissection. For that, we use adrenaline, 1:1000 ml dilution. This is where we use 1 ml in 200 ml normal saline.
Yes. So that is the routine concentration we use. So this is adrenaline.
Yes.
Okay. So keep it. Usually we use a 10 ml syringe to infiltrate it. And what is the angle of infiltration it should be?
First, to separate the anterior vaginal wall from the cystocele, 45 degrees.
Okay, so it all depends on the angle at which you are inserting your needle to infiltrate this space is very important to understand. Now, it depends on where you are going to dissect. If you are going to dissect first between the vagina and the bladder, the angle should be 0 to 15 degrees, more or less straight. If you are going down, if your aim is to dissect between the bladder and the cervix, then it should be 15 to 30 degrees. Okay, where you are pushing your fluid is very important. Just pushing it anywhere is not going to help you. Now, after this thing, I want to discuss one very important thing, Nipasa. How many kinds of, when we give the first incision, how many kinds of first incision you have seen?
Ma'am, I have seen in our OTs we use the
transverse incision at cervicovaginal junction. Yes. Very good. Have you seen anything else?
Inverted T shape.
Inverted T shape. Very good. Then
Y shape.
V shape.
V shape.
Inverted V shape.
V shape.
So 3 kind of incisions are usually done. One is first just simple transverse incision. Other is V shape, inverted V shape, or inverted T shape, as you said correctly. So what is the purpose? When we give that inverted T shape or inverted V shape, what we are doing is we are reflecting the flaps of vagina before only. These are for repair of cystocele. So all the 3 techniques have their advantages and disadvantages. what I prefer to do first is give a transverse incision and first dissect bladder from the cervix, okay, away from the cervix, which is still attached to vagina. Okay, and when we do cystocele, then you can hold it and then you can dissect between the vaginal wall and the bladder. Okay, but you would have seen people, they give inverted T. Let's take an example of inverted T. When you give inverted T, that time you raise the flaps then and there, then you go below the bladder and separate it. So both the separations are done as the first step.
Yes.
Now, what are the advantages and disadvantages of this technique is, advantage I'll tell you first, when you are raising the flaps in the very beginning of the surgery, you have the uterus below as a support. So in some hard structure, when you are doing blunt dissection or sharp dissection, it is much easier as compared to when you have already removed the uterus and then you are trying to create the flaps. Is it clear?
Yes.
Okay. If you don't understand, you let me know, because if you are not understanding that, I understand that our viewers are also not understanding. We can repeat it as many times as you want. Okay. Then when we are raising, now what is the disadvantages of doing this inverted T and raising the flaps, or V and raising the flaps is, see, anyway you are not going to close the cystocele or do anterior colporrhaphy till you have removed the uterus. And in best of the hands also, given all OT circumstances, at least the minimum time of removing the uterus is around half an hour in our setup. Okay, so by the time the uterus is out and you reach the bladder and the vagina level, patient is already bleeding that much. Even if you have given adrenaline has a very short, around half an hour effect. So when actually you want it to be a bloodless field, all vessels, the adrenaline effect goes away and vessels start oozing. And half an hour, you are keeping the surface open for infection, won't settle in so fast, but if the medium is right, there is a chance that the tissue can get infected. Okay, so because of these reasons, so there is one advantage. What is the advantage? That you get a support to dissect.
Yes.
That makes it much easier. What is the disadvantage? First disadvantage,
Source of infection, trauma,
and so for half an hour, for no reason, you are keeping
Yes.
the raw tissues open. So there is a little chance that might get infected. Usually in OT this doesn't happen, but there is a risk, whatever small it is. Second thing more important is that the tissues will keep on bleeding for half an hour unnecessarily. Third is, even if you say that I have given adrenaline, it is not going to bleed, but the adrenaline is a short lasting drug. The effect lasts only for half an hour to 40 minutes, okay? So by the time you finish your hysterectomy and you reach to do the job at the bladder level or bladder buttressing suture, the effect of adrenaline is already weaned off. So what we do instead here, that we give a transverse incision first, we inject adrenaline only in that plane, which is between the cervix and bladder now, and then we dissect off this plane, we finish vaginal hysterectomy. Then when we are doing cystocele, we inject again between the bladder and the vaginal wall, and then start creating the flaps. Is it clear?
Yes.
Okay. Then, after we have given the incision and pushed the bladder up, then what do we do?
Then we open the UV fold.
So you can open the UV fold, but many a times when it is tricky, I personally feel it is much easy to open the POD first. I always do that. So opening POD first, and especially for beginners, it is very easy. So why not do that? So how do you do? What are the instruments which are required to open the POD? So first, there is a speculum. You have to retract the posterior vaginal wall and keep the rectum pressed. Otherwise, you will injure the rectum. Then valsalem seed, what you have to hold? It was holding the anterior first. What do you want to hold now?
The posterior.
Yes. So hold the posterior lip. Now remove it from there. Hold the posterior lip and give traction. When you give traction, then you can see the vagina which is overlaying the pouch of Douglas. Then with what instrument you use to tent the vaginal wall, posterior vaginal wall? Cockers. So straight cockers. And why cockers we use? Why not simple clamp, straight clamp?
because these are teethed, ma'am,
Huh.
so the grip is better.
So there is a pair of teeth here, and so it just grasps it nicely. The chance of slipping is not there. If you use a simple clamp or simple artery, it doesn't hold with that good grip. We really need this grip, and just you tent, and then when it is tented, then what do? You nick it. With which instrument?
With tissue cutting.
With tissue cutting scissors. So scissors has to be long tissue cutting and sharp scissor. Blunt scissor, which you can keep on doing, it will not cut. So sharp scissor is a must here. So after this, you have entered the POT. Then what you have to do?
Then we laterally
Sure.
extend both our incisions so they meet the
Yes.
lateral.
Very good. So for that, actually you didn't tell what instrument we use to cut, to give the incision. Anterior T-shaped or transverse incision.
And there we use cautery.
We use monopolar
Monopolar
cautery. So what else you can use if you don't want to use monopolar cautery?
We can use
Sure.
so BP handle and the blade, ma'am. So
Which
blade,
number blade?
This is number 22, which has a belly, ma'am. So with the belly, we should take the incision.
Very good. So again, you would have seen even cutting with this is not wrong, even cutting with that is not wrong. Both have an advantage and a disadvantage. Advantage of cautery will be
Bloodless.
bleeding will be less. Advantage of what is the disadvantage of cautery? Because it burns. So the planes, the distinction of planes doesn't remain very clear to you. So you cannot make out tissue because all tissues get burned there. So everything is charged. So it is little difficult to make out very clearly. But if you use the knife blade, the planes are very sharp because you have not damaged. You can see the different consistency in different layers. But again, the problem is it might bleed a little more. So it's up to you which one you want to use it. I will suggest when you are starting your surgery, better to use a knife because seeing the planes is more important in the beginning part. Then when you have this idea how these things look, when you close your eyes also you can find out where to cut, then you can use cautery. Then what do you do? So we have given incision, we have opened pouch of Douglas. Then what do you want to do?
And then we try to deliver the uterus.
And before that, actually, if the uterus is totally out, if it is procedentia, what you are seeing is easy to go inside it. But suppose it is just a third degree UV prolapse, okay? Sometimes it is not very easy, or we are doing hysterectomy for non-distant vaginal hysterectomy for non-prolapse patient. It is not. So what I always tell, whenever you are proceeding to hysterectomy, the first clamp is
and the
Mechandron,
the cardinal and the uterosacral together.
Complex. So Mechandrots and uterosacral ligament together as a complex we have to do. So I always teach my students that whenever you have to cut this, opening of one pouch and retraction of the other organ is okay. Okay, so if you have opened the posterior pouch and still you feel that UV fold is high up, you can just retract the bladder and see it and clamp, cut and ligate. Okay. Once you have done this, uterus comes little more. It is easy to deliver the uterus as you say and cut the anterior. So for cutting Mechandrots and uterosacral ligaments, it is not required that both the pouches should be open. Okay. But anterior pouch has to be open before you go into uterine artery. Okay. Bladder has to be pushed properly. So these are the two important things you have to remember. Now tell me one more thing. Now, very important thing. You had asked me last OT also, and now you will try to give me answer. You have two kinds of clamps there. Can you pick up both the clamps?
So there are two clamps. One is curved and one is straight.
So which clamp? How do you decide that for this particular vaginal hysterectomy I want to use curved clamp or I want to use a straight clamp?
When the pedicles are nicely visible, then we can go ahead with the straight clamp. But if it is the pedicle is higher and the end is not visible, then it's better to use the curved clamp.
Yes. So you have understood. Let me explain it a little more. So this is a straight clamp. This is a curved clamp. So what she's trying to say that give me this uterus. Suppose this is the pedicle and this is the vaginal introitus. Let's imagine. and you can see it entirely, and you have lot of space here, as it is in case of severe third degree prolapse or presidentia, where the uterus is totally hanging outside, or you have dissected so much that uterus has come out. In those situations, you can always use a straight clamp. Now, what is our aim here? I want to keep on seeing this tip. But if suppose it is still inside, in deviate, suppose it is still inside the vagina, I am not able to see this end. So in that situation, I want to use this clamp, which is curved. So when the space is less, I want to keep on, it is much easy to see the tip here if the clamp is curved. But again, I will tell you that if you have no choice, suppose you have one set of clamp, you want to use a curved clamp, but curved clamp is like very bad quality, it is opening and jumping and old set. And if you have a good straight clamp, please use the good clamp. And when both the clamps are good and you can make a choice, then the idea is that when you cannot, you have less space, like I'll give you two extremes, precedentia and NDVH. So for NDVH, it is always better to use curved clamps because we have to see the tip to pass our suture material. And in case of precedentia, where everything is out, we prefer to use straight clamps because there you can see everything, whatever, wherever you want to put, you put, and you will be able to see the tip of your clamp. Okay. Then what do we do? Then,
so usually we take 2 clamps.
Very good.
And after that, after clamping, we cut and then we transfix the ligament.
So for gynecologists,
cut
ligate is equivalent to Bollywood mein
light camera
action. Okay, you have to remember all the time. So now when you have cut it, again, which instrument you want to use for cut, whether you want to use, okay, I'll give you Nipasa 3 choices. For cutting, you have now blade with you,
yes.
You have cautery with you, and suppose we have a bipolar cautery also, which is also known as biclamp, and then suppose you have a scissors also, a pair of scissors also. So 4 instruments. How do you decide which instrument you want to use for cut? Clamps you have told,
yes.
Cut.
If the ligaments are nicely out, as in case of precedentia, then, and if we are experienced, then we can go ahead with the bipolar cut.
So important, very good. So again the same thing. If I am able to see where I am cutting and nothing is touching here and there, no instrument, no part of the body, then I can nicely take, and because it has dual function, it calculates also and it cuts also. But if you are going to do it inside, if you half the pedicle is inside the vagina, half is outside, I never teach students to do this step because you don't know, because vagina is such a small narrow space. Never do that when you cannot nicely see it and retract all the things outside. When it is clearly visible in front of you, then only use cautery. Otherwise, what do we prefer to use? Again, blade has the same problem because when you are cutting, you cannot see where all you are going. Okay, so I don't prefer to use in vaginal hysterectomy knife or blade, but scissors are very much protected. Okay, so it cannot do damage other than tip both the blades. I am not worried that it will overshoot and cut something else. If you are using a knife, it can cut some structure which is just next to it. So it will never overshoot and cut it. You have much better control with scissors as compared to knife. So I prefer to use this. Now there is another thing. We have already made a video on biclamp. This is a very popular method, and so we don't do it usually. But biclamp means with a bipolar cautery. So you don't have to do this clamping again and again. It clamps and then it cuts also, like we do in laparoscopy. But I have done a video before also and explained that why don't I prefer to use biclamp, because it cuts in very small bits and parts. One thing, it takes a lot of time. The other thing, I have explained that, you please go there and see because this is another topic. So personally, if you ask me, biclamp I do not like to use for vaginal hysterectomies. I use either monopolar cautery or scissors to cut the pedicles. Okay. Then clamp we have done, cut we have done, and ligate. So how do you ligate? So you have told about cutting and clamping. Always do clamp. We have told you whether straight or a curved clamp. always use two, because if one slips, you are you are at safe side. You are still holding with another clamp, which is very common with gynecological instruments. And second thing, you have already told which instrument to use while cutting. Now, what about the time?
In a vaginal hysterectomy, there are three times that we
To do this cut clamp and ligate.
Yes. First is the ligaments, the Meccan rods, and the uterus. There, one time we can transfix.
Yes.
For uterines also, one time it's enough. But since convex structures, three structures we are taking at the same time, and it has the lateral pull also.
Yes.
Just to be on the safer side, first free tie, and then we take the second transfix
suture. So it's very simple. Nipasa has made it very crystal clear and very simple. So vaginal hysterectomy is only 3 clamps on one side, 3 pedicles on one side, and 3 pedicles on the another side. It is always clamp, cut, and ligate. Clamping and cutting is always we have discussed. And for ligating, first 2 pedicles, only 1 tie transfixation is more than enough. But for the upper, the last pedicle, which is a broad pedicle which carries 3 structures and is most of the time under traction, we prefer to do 2 ties. First is the lateral is the free tie, and medial is the transfixation. Many people ask about suture material. What suture material you use for vaginal hysterectomy?
Pedicle we use, ma'am. There is number 1, 1020.
Which one we use? Only that numbers, because we will not fill our mind with too much information. We'll simplify things. So number 1. For all the pedicles we use number 1. We'll tell you where we use 20. So only 2 kind of suture materials we use in vaginal hysterectomy. Number 1. Now many people keep on asking, see, don't get confused about what suture material you want to use. So if you tell me to classify suture material, there are 4 categories. Okay? And when I'm telling these categories, I'm not going to tell you what they are made of and what is their biochemical structure. I'm just telling you for clinical purpose how much a PG or how much a gynec should know about suture material. So the first category of suture material is very rapidly absorbing suture material. Give me some examples, Nipasa. Monocryl, vicryl rapid, and catgut. So the time for them is 7 to 10 days. And when I say time, it means the time for which they hold the tissues together. So 7 to 10 days, if you have put a vicryl rapid, it would hold the tissue together. Though to come out, to get dissolved and come out of the body and not being visible there, it takes much longer time, up to 2 months. Okay, so 7 to 10 days for catgut, vicryl rapid, and monocryl. Second group of suture material is delayed suture material, which is this blue colored vicryl, which we use for most of vaginal hysterectomy, and only this suture we use for vaginal hysterectomy. This is blue vicryl, and this is a delayed absorbing suture. It starts losing the strength in 3 weeks time, but remains in the body for around 6 months. Not 6 months, up to 3 months. Okay. Then the third kind of suture material is very delayed suture material, which is PDS. It is the time which it remains in the body is around 6 months. Okay. Then there are non-absorbable suture material, which are silk, cotton, proline, or ethicon. Okay. So when we are choosing the suture material, it is not just the number, and I hope you know the numbers, how it is numbered. Suture material 1 means
it is the thickness.
1. It's not the thickest, there is some number, yes. 1. So if you go to the thicker side, it will keep on becoming 2, 3, 4, 5. Okay. When you are saying 0, like the other suture material you show me, 20. So when they write like this 20 suture, but when you imagine it like 0, 0. 10 means 0, 20 means 0, 0, 30 means 0, 0, 0, 40 means
4 times
0. Okay. So you have to remember, as the number of zeros is increasing, it is becoming much, much more thin in size. Okay. So 30 is thinner than 20. Okay, understand? So you always remember, it is not 20, it is 0, 0 means 20, so it is thinner than 10. Okay. Now the thing is, I believe that okay, size of suture material is important, but more important maybe or equally important is the size of needle. Okay, so when you have a thicker suture material, you have a thicker needle with it. When the suture material is thin, you have a thinner needle with it. So most of the time when we are handling the thicker tissues, the tougher tissues, if we use a very thin needle, it will bend. Okay, so to do transfixation for all the pedicles, we need a good strong needle. Okay, and the curve is also important. So one zero, if you see, the needle might be thick as it, but it is too less curved. Okay, more open kind of needle. So we want a good curve also and a strong needle. So for entire vaginal hysterectomy, to do all the pedicles, we use number 1 Vicryl suture material because it is a thick suture and it is a thick needle which can handle tough tissues. When we put suture for bladder buttressing, many people have asked this question too. So what happens when we are doing bladder buttressing? We are not taking tough vaginal tissue. We are handling very fragile or very delicate kind of pubocervical tissues. So when pubocervical fascia is a thing already in the patient, these patients when we are doing vaginal hysterectomy, it is already attenuated. Okay, so when we take this tissue, there is chance that there might be cut through with the needle as well as with the suture material. So on those situations, we use 2-0, which is a small needle, thin needle, and thin suture material. Is it clear? Okay. We'll keep it here. Then after you have done all pedicles, then what next?
Then we deliver the uterus.
Uterus will have come out when you are cutting only.
Yes.
After that you suture all the pedicles. Then vaginal hysterectomy part is over. Then what do we do?
Then we check for the hemostasis.
Hemostasis is very important. So here again, one of our what I have seen many people, they hold the pedicles and pull them and check for hemostasis. I totally am against it. That once you have tied, even if you are doing abdominal hysterectomy, you have tied, you be sure then and there. If any point is there, coagulated then and there, and don't keep on checking it later or by pulling, because it might slip. So you are doing more damage by checking it than helping it. So we have devised a very nice idea and we call it underwater visualization. So we take a 50cc syringe and with force we push the saline inside and see the water. If the water has some streak of blood in it, that means there is bleeding for some time. Then we localize and coagulate that. Okay. Most of the times, because we are very careful when we are tying the pedicles, that we achieve hemostasis then and there. So usually we don't have to do extra effort that time. We just check it. So for that step, you need a lot of saline, a suction, and a kidney tray, and a syringe, 50cc syringe to push the saline inside and see the pedicles. Okay. After that, after we have done, after we are sure that all pedicles are nice, hemostasis is, then what is the next step?
The peritoneal closure.
Very good. So peritoneal closure. Now you tell me, Nipasa, or you can tell. Okay, think in your mind what suture material you will use for peritoneum. It's a thin, delicate structure. Suture material 2-0. I don't want to take number 1 because it's a very delicate structure. If I put a big needle there, it will tear off. Okay, so 2-0 will do, and we have explained again the step many times how to take bites. And if you have confusion anyway, you can ask us anytime. When we are closing the peritoneum, you have to always ask the sister.
Counts,
knobs and instruments should be. Because if it goes inside the peritoneum, then it is a blunder. So that is the moment then you have to check for instruments and knob counts. Okay. After you have closed the peritoneum by doing a persistent suture all around, then what do? Then we'll do cystocele, if there is a cystocele.
Yes.
So we are not going into details of cystocele and rectocele repair today, but what I have already told you, incision we give at this stage. Now when we have finished everything, when we have closed the peritoneum, we hold the vagina with Alice and then we start giving the incisions. Some people do it before. We have already discussed advantage and disadvantage of that. So when we hold this flap of anterior vagina to do the cystocele repair, then again at this moment we infiltrate the subvaginal tissue to create a bubble of safety. Okay, and then dissect, raise, slave, do bladder buttressing. Again, we have already told bladder buttressing, what suture material we have to use is 2-0 Vicryl because of the size of the needle and thickness of the suture material. Now I ask.
Ma'am, we give it at the angle of 0 to 10.
Yes, 0 to 15 degree because we have to mark 0 to 10 is also okay. Means it is more superficial as compared to because the plane is here.
Yeah.
Then one thing, now there is a question, very important question. Suppose Nipasa is doing vaginal hysterectomy for the first time, independent. There is nobody who can help you and you have followed all the steps together. When you open this flaps, when you raise the flaps to do this cystocele repair, suddenly fluid started coming. What is happening?
That is our fluid, the injected.
So she is so confident. Otherwise, she's so confident. This is actually the fluid which we have injected. That's what is coming out. So don't worry. So
That's
if by
why
chance,
prophylactically we use pyridinium tablets. That is our pre-op preparation.
so what it does, pyridinium stains the urine
Yellow color.
orange color,
Orange color.
or yellowish orange in color. So if you have by mistake, if you have opened the bladder, then yellow color fluid should come out or orange color fluid should come out, not the diluted one, like not transparent. So it is a very important step to prevent or to diagnose, and more important, I think it has much more negative predictive value than positive predictive value, because when we used to do initially, it was a heart attack as soon as you see fluid coming out. You are always worried, have you injured the bladder, have you injured the bladder. First thing, if you are careful, please don't bring it to, like, don't keep this doubt or this fear in your mind that you will injure bladder. Bladder is far away from the plane which you are going to dissect. If you have done hydrodissection, created a bubble of safety, it is very, very unlikely that in a simple case of vaginal hysterectomy, you will injure the bladder. And even in the difficult cases, sometimes if the bladder opens, don't worry. Just either call the urologist or suture it back with some 2030 Vicryl and keep the catheter for 3 weeks or 4 weeks for continuous drainage. There is nothing to be scared of. You should not do bladder injury. You should try to prevent it with whatever way. First thing, it is not very common to do it. And second thing is, even if you have done it, it can happen, and early diagnosis is more important. Early diagnosis and repair is more important. Okay, so pyridinium helps in both these situations. Now, some people have asked me this question also, Nipasa, that sometimes whether when you do, it's not that you have opened the bladder, but when you are taking that pubocervical fascia, okay, if by mistake you enter the bladder, what will happen? Nothing will happen. Okay, actually you should not use, like, vagina should not be connected to bladder, otherwise you will land up with fistula. And just a prick, suppose you pricked it and some orange color fluid came. You know that it is just one prick, nothing will happen, because bladder has this capacity, its muscle has the capacity to come back and close that, just periprick won't. Okay, so many times when we do suprapubic catheterization, we are actually puncturing the bladder, and later we do not do anything for that. When we do TVT, a retropubic procedure, sometimes the bladder, the probe goes inside the bladder. We just remove it, we do not have to repair it. So small little pricks in the bladder will heal by themselves. You don't have to do any active intervention for that. Now I want to ask you one question. What is this? What this packet is?
This is the 4x4 gauze material which we use for gland dissection.
Yes, when we are
pushing the bladder
up, we use that. Then any other instrument you have left, then we'll proceed. What is that?
This is the suction.
This is one very, very important thing. We want to, more than gauze piece, I prefer to use suction. Because to keep the field clean, and suction tip sometimes helps in dissecting the tissues also. Very important this is. Then these are those two, what is this, show me?
These are two muscles.
And where do we use it?
To hold the suture with the clamps.
Yes. So suture material. Yes. So there are two clamps. Uterine artery clamp, suture, we never keep it long. So the first pedicle and the last one. First is the uterosacral megatrods. We always keep two threads attached to it, and we use to hold this curved artery with that. Okay, and then when we reach up, we do the cornual structure, and there we hold the round ligament or the cornual structure pedicle with this. This is to differentiate that which one. Once you have finished vaginal hysterectomy, all pedicles you will see that they come together. Sometimes it becomes difficult to find out which one is round ligament, which is uterosacral. So now you know that uterosacral is this, and it will be holding two suture materials together. That's how we differentiate. And this is when this mosquito is holding single suture material, that is round ligament or cornual structure. So it helps us when we are seeing the structures to take it in one sequence while doing the peritoneal closure. Anything else? You have Alice forceps. Where do you use these Alice forceps?
Alice is used to hold tissues.
So tough tissues when you are holding. You have to raise when you are raising the vaginal flaps, when you have given the transverse incision and pushing the bladder up. All those things you hold it with Alice. So we need good holding forceps. Fascia. It is very important. Okay. Then anything else we have left here?
Suture cut.
Suture cutting is to cut to the suture material. Okay. One important thing I'll tell you again. Now I told you that the entire hysterectomy, if you have vaginal hysterectomy and repairs, if you have 3-4-2-0 suture material and 3-4-1 suture material, you can start and finish hysterectomy. Only for one step, we use a permanent kind of suture in normal practice, and that is when the patient is having entrocele and we are doing McCall's scaldoplasty. So internal McCall's scaldoplasty is always done with a non-absorbable suture. We take either proline or ethylon. Usually I use proline 2-0 or 3-0 to do the peritoneal closure or the internal McCall's. Okay. Why is it so? I really want a strong suture material to hold this, because once you have removed uterus and everything from below and patient stands erect, the entire abdomen, bubble and whatever content is there puts pressure on this. Earlier when uterus was there, pouch of Douglas was behind, so directly it was not getting the pressure from all the abdominal organs. Uterus in antevertebral or retrovertebral position was like a protection for the pouch of Douglas. But now that area, that apex of the vagina where everything is together, the pouch what we are closing, is in direct contact with all the abdominal viscera, and when the lady is standing erect, then it will create all pressure in that particular place, which will increase the chance of risk of wall collapse. Okay, so very important that whenever you are doing internal McCall's scaldoplasty and patient already has an entrocele, she is more at risk. So we always use a proline suture, either 2-0 or 3-0. And the idea is whenever you are using a non-absorbable suture, it should not come out through the vagina. So in internal McCall, we take what suture bites we take. We take uterosacral ligaments, then multiple bites in the high peritoneum, posterior peritoneal pad of fat, and then we come out and take this. We are not coming out of vagina. So if the permanent suture is inside the peritoneal cavity, doesn't come out the vagina, so there is no risk of infection. It should not come out of the vagina. One thing. So initially you told me that you use it to retract the posterior vaginal wall. Okay. Most of the surgery we use this speculum, the bigger speculum, the posterior vaginal wall. Can you tell me one indication where we retract the entire vaginal wall with this while doing vaginal hysterectomy?
While repairing the posterior colpoperineum that time.
For doing it? No, that time you don't have to. There is nothing to retract. Uterus is removed, cystocele is repaired. Bigger speculum to hold the entire wall. I have told you during the surgery. So,
and there is adhesion.
No. While we are closing the peritoneum and we want to approach the prerectal pad of fat, that yellow prerectal fat, you cannot retract with any other instrument. You need to take your posterior retractor up and retract all the structures that will be, even if you are. So for entrocele repair, this instrument is It retracts the anterior part, and when we are working on the posterior part. So may it be high peritoneal flowsure to see the prerectal part of fat, or when we are doing medical scaldoplasty, you have to hold it in the opposite direction. Is it clear? Anything else then you want to ask? I think we have finished all the instruments. Tell me what it is.
If there are small bleeders, ma'am, to coagulate. So
Yes.
this is
This is called touch forceps.
touch forceps.
And we have to touch that monopolar cautery. If you have bipolar clamps, you can do that also, but
Right.
most of the times we use this.
Touch forceps.
So, vaginal hysterectomy actually bleeds much more. Any vaginal surgery bleeds much more as compared to abdominal because of the tissues and good vascularity there. And many of the patients we would have given Evular cream for some healing of the ulcer, or postmenopausal patients we would have given. So bleeding is comparatively much more. But small bleeders, if you keep on coagulating, you keep on getting a clear field. If we keep on bleeding, then it is irritating also. You are worried also about the blood loss, and your fields are never clear. I think that's quite a lot of information about vaginal hysterectomy. If we have left something, please leave a comment below in the comment box, and we'll try to answer all your queries. Thank you.